Hi and welcome back to another video of Medic Notes. This video is on bone tumors. Bone tumors can be divided into primary and secondary tumors. Metastatic spread from other cancer types is the most common cause of bone cancer. The most common primary sites being renal, thyroid, lung, prostate, and breast. The most common site for a bony metastasis is the spine. The risk factors for bone tumor are genetic association, previous exposure to radiation, or alkylating agents and chemotherapy, and benign bone conditions like Paget's disease and fibrous dysplasia. Both increase the risk of osteosarcoma. The main symptom of a primary bone tumor is pain. This is typically not associated with movement and is worse at night. Often deemed a red flag symptom. As the tumor enlarges, a mass may be palpable. If the patient presents with a fracture without a history of trauma, suggesting a pathological fracture, a bone tumor may be suspected. Primary tumors can be classified through tissue type, which are bone-forming, cartilage-forming, fibrous tissue, giant cell tumors, and marrow tumors. This table shows the benign and malignant types for each category. I will cover on a few benign and malignant conditions. For benign we have osteoid osteoma, osteochondroma, chondroma, and giant cell tumor. First, osteoid osteoma arise from osteoblasts. Common site is at metaphysis of long bones, such as proximal femur or tibia. X-ray shows a small mass with radiolucinitis with a rim of reactive bone. Management is conservative, through serial imaging. Overall good prognosis. This picture shows an osteoid osteoma at the lesser trochanter. Second, osteochondroma. They form as an outgrowth from the metaphysis of long bones, covered with a cartilaginous cap. Usually are asymptomatic and slow-growing. On X-ray, they show as a pedunculated bony outgrowth from metaphyses. Conservative management, and surgical resection for those with significant deformity or neurological symptoms. This picture shows multiple osteochondromas affecting the left knee. Third, chondroma, arise from chondroblasts, common among 20 to 50 years old. On X-ray, they appear as a well-circumscribed ovolucency with intact cortex. Most asymptomatic and small chondromas can be observed. However, larger symptomatic chondromas may require removal with curettage and bone grafting. Lastly, giant cell tumor. They arise from the multinucleated giant cells and stromal cells, affecting epiphysis of long bones, most commonly the distal femur, proximal tibia, and distal radius. X-ray shows an eccentric lytic area, giving it soap bubble appearance. Surgical resection is the treatment of choice, potentially requiring bone grafting or reconstruction. Next we continue with malignant bone tumors. First, osteosarcoma is the most common malignant bone tumor. Can be seen in children or elderly. Common site is metaphysis of distal femur or proximal tibia. Characteristic X-ray findings are Codman's triangle or sunburst pattern. Can be diagnosed by bone biopsy, then managed by aggressive surgical resection with systemic chemotherapy. Second, Ewing's sarcoma. It is a pediatric malignancy, most commonly seen in diaphysis of long bones. X-ray might show onion skin appearance, managed by neoadjuvant chemotherapy followed by surgical excision. Third, Chondrosarcoma, arising from cartilage. Common site is axial skeleton. X-ray shows lytic lesions with calcification, cortical remodeling, and endosteal scalloping. Low-grade lesions can be treated using intralesional curettage, whilst wide-on-block local excision is the preferred for intermediate and high-grade lesions. To summarize, benign lesions are often sharp and well-defined, lacking soft tissue involvement and no cortical destruction. Malignant lesions are often poorly defined with rough borders, involving soft tissues and have cortical destruction. That's all for this video. Thank you.